This is our lecture number 33. We're going to be expanding upon some of the things that we talked about in our previous lecture concerning the DSM, Diagnostic and Statistical Manual. And I want to try to streamline this for you in terms of classifying behavior disorders. And hopefully this will be helpful to you as we go along. So let's begin this by taking a look at what I would call a convenient way to classify behavior disorders. Again, I'm using the DSM as a framework, but I've tried to simplify things as much as possible. We're going to take a look at anxiety-based disorders, and there's two sub-areas to this, neuroses and psychoses. And then we'll take a look at personality disorders, and then what we'll do is we'll take a look at organic, or what we call biologically based disorders. So again, this is going to be a streamlined version, very much a streamlined version of the DSM. You can, of course, take advanced courses in psychology where for example, if you take a course in abnormal behavior, you really go into these things in depth. And again, in the survey course, we simply can't do that. But again, I want you to be able to hang your hat on a few things. And again, I've tried to simplify it as much as possible. And I think hopefully this will work for you. So when we take a look at neuroses, we're really talking about individuals who have these fears inside themselves, and really anxiety is the absolute cause of these fears that a person has, these urges, these thoughts, these feelings. And if you think of it in Freudian terms, we're really talking about repression being ineffective in terms of a person who has an anxiety disorder like this that we commonly refer to as neurotic behavior, neuroses. So when you take a look at the symptoms, neuroses is not something that develops quickly. It takes a lot of time. Generally, neurotic individuals are very much in touch with reality, but it's obviously a very troubled reality. There's mood swings, there's depression. There's also biological symptoms, headaches, heart palpitations, sweating, excessive sweating. So again, when you take a look at neuroses, you're really talking about an anxiety-based disorder that is certainly not as severe as what you would see in the case of psychotic psychoses, which we will take a look at as we go along. So the major subtypes of neuroses, certainly phobias, of which there are many. We talked about some phobias previously, people who have fears of flying, for example. Again, this is neurotic anxiety. It's focused on a particular situation, a particular object. People who are afraid of crowds, people who are afraid of going outside their homes, people who are afraid of heights. Again, these are all common phobias, and again, it's neurotic anxiety focused on an object or a situation. We also have what we call obsessions and compulsions, where an individual has these thoughts that keep reoccurring, and actions that keep reoccurring. For example, some common obsessive and compulsive behavior. Individuals who engage in excessive hand washing, where they might do this several hundred times a day. Or people who are obsessed, for example, with turning lights on and off, and do so, many, many, many times over the course of a day. I mean, this is a obsessive, compulsive kind of behavior. And again, there's these actions that they must repeat all the time. There are these thoughts that they always have all the time, and they simply can't put that, they can't repress those thoughts. Repression is very ineffective in dealing with this. Certainly hysteria, which we've already talked about in the context of Freud's theory. It's these physical symptoms that exist that, there's no actual organic basis to them. Some examples of this, a man, for example, that masturbates frequently might develop a situation where they suddenly lose the paralysis of their hands, for example, or a woman who has this excessive fear of having sexual contact with her husband develops paralysis of the back. I mean, these are all classic symptoms of hysteria. Physical symptoms, again, there's absolutely no biological basis to them at all. They're something that obviously occur as a consequence of this buildup of anxiety that you see in an individual. When we take a look at psychotic-based behaviors, we're really looking at a difference, a dramatic difference in degree in terms of the impact of anxiety and the inability to deal with anxiety. So, for example, I always say neurotic individuals are emotionally crippled, but they still are able to carry on and what I say, slug it out with life on a daily basis. But in terms of a psychotic individual, that fear reaches such a high level that they withdraw completely from life. That person is one that we would classify as being psychotic. So again, neurotic individuals are able to kind of deal with their anxiety to a certain level, but a psychotic individual just absolutely gives up. They can't do it any longer. So it's a distinction, an important distinction in degree to which anxiety influences an individual. And again, in neuroses, an individual can generally cope with these things, but in psychoses, an individual can't. Schizophrenia, this is an anxiety based disorder. Again, under the general category of psychoses. And this is really very severe intellectual, emotional, and perceptual changes in terms of how an individual perceives themselves. And there are different varieties of this. Simple schizophrenia, these are individuals who slowly lose social attachments. They lose interest in interacting with other individuals, and generally they are left in a very apathetic and indifferent state. So we call that simple schizophrenia. In hebephrenic schizophrenia, this really is the classic stereotype of insanity. It is very, very severe personality disintegration. Many of you may have seen the movie from a number of years ago, One Flew Over the Cuckoo's Nest. And in that film, the actor Jack Nicholson played this individual who could be classified as hebephrenic schizophrenia. Schizophrenia, again, very severe personality disintegration. We also have catatonic schizophrenia, and that's where individuals become mute. They don't interact at all verbally. They are preoccupied by these thoughts that they have. And indeed, their ability to function normally in society is just severely impaired because of the fact that they, have these disruptions in terms of their ability to socially interact normally. And then we have paranoid schizophrenia. And these are individuals who are really convinced that other people are after them. that they believe, for example, that they occupy a superior status. So there are other individuals who are constantly trying to take them down. If you take a look at this movie from a few years ago, A Beautiful Mind, in which the actor Russell Crowe played the Nobel Prize winning economist John Nash. This is John Nash right here, who was at Princeton University, won the Nobel Prize for his work on what is called game theory, considered to be some of the most important work ever in the field of economics. He was an individual who, on the one hand, was incredibly brilliant, obviously winning the Nobel Prize, but also suffered tremendously from paranoid schizophrenia and believed once again that other people were after him, and this absolutely destroyed him. Had it not been for his wife, who was incredibly supportive of him, he probably never would have been able to make it through these bouts of paranoia. So indeed, different classifications, subclassifications within schizophrenia. We also, under this general category of psychoses, have affective reactions. Again, these are mood disorders that people experience. They can be very excited or very depressed, very optimistic or very pessimistic, very, very happy or very, very unhappy. Again, they alternate between these two. This is also referred to as bipolar disorder. So affective reactions. We have also under this general category what we call manic reactions, and these are individuals who show this excitement and deteriorating judgment in terms of the relationships with other individuals. And then there's depressive reactions where depression and mania alternate with each other. Again, this occurs over a very, very long period of time. It's called bipolar disorder, but generally these individuals end up in a very, very depressed state. So again, affective reactions that we divide into what we call manic reactions and depressive reactions. We also have personality disorders, and it's important to make the distinction here that, neurotic and psychotic based behaviors are really a product of trying to deal with anxiety. Anxiety is the root cause. Personality disorders don't really result from anxiety. They're usually marked by the inability of an individual to adapt to their social environment. They really can't establish any kind of rational, stable, rewarding relationships with other individuals. They simply don't have the capacity to do this. Personality disorders, the two major subtypes. One that we call antisocial personality. These are individuals who have absolutely no guilt at all about misbehavior. They can't form any kind of lasting social relationships. And certainly a special case of this is what we call the psychopath. You see there two individuals, Charles Manson and Ted Bundy, who are classic cases of psychopathic behavior. Very egocentric, narcissistic, great difficulty with impulse control. They're very irresponsible in their behavior. We all experience frustrations in our life over the course of the day, but they can't tolerate those frustrations at all. Their judgment is very poor. They seek immediate gratification. So again, this, the special case of the psychopath, which, many people obviously are very interested in terms of what psychology has to say about this. But it's really under this general category of what we would call antisocial personalities. There's also sexual deviance, and this is a category that I think has been changing dramatically with each new iteration that is each new revision of the DSM. But generally speaking, the label of sexual deviance would be applied in the case of a person whose sexual behavior is, very compulsive. It's destructive, not only to that person as well as to other people. There's a lot of guilt that's associated with a lot of anxiety. They're causing discomfort to other individuals. That's when we would use this category of sexual deviance. We can divide this really into two areas. There, of course, are paraphilias that individuals experience, where certain physical items, objects, produce sexual arousal. There are things that have been associated with sexual behavior patterns that really interfere with normal sexual relationships. So that becomes the object of their attention in terms of sexual arousal, are these stimuli that are not normal in terms of eliciting sexual behavior. They become very obsessed with those. So that's paraphilias. We also have pedophilia. And if you take a look at what the DSM says, it's really, individuals who experience this over an extended period of time, at least 6 months, where they have these arousing fantasies and sexual urges that have to do with prepubescent children. So again, two general categories under sexual deviance: paraphilias and pedophilias. Now, the last category that we want to take a look at is one that I think it has changed the most in terms of what we know. There are many types of behavior disorders that we can absolutely trace to some kind of a physical change in the brain, maybe damage to the brain, maybe an imbalance in terms of various neurotransmitters and hormones, or maybe even to a genetic influence. But as we've become more sophisticated in terms of being able to do brain scans, this is a category that seems to be expanding more and more. Again, because of our ability with this new technology to be able to visualize the human brain. So again, this is not an exhaustive list by any means, but I think it will give you, a little bit of a taste of the various types of biologically based disorders. First of all, melancholia. This is something that we see in women, in which there's very severe depression that occurs, and it occurs with the onset of menopause. That's the time at which a woman is shutting down in terms of her ability to produce an egg, because her hormones are shutting down. Oftentimes, women lose their sexual desire during this period of time. They don't believe that they're attractive any longer. And again, this is something that as we learn more about it, we're learning, for example, that when the hormone estrogen begins to shut down, it may be in part responsible for this severe depression that occurs at the time of menopause in some women. Again, this is referred to as melancholia. When we take a look at some other disorders biologically based, certainly the consequences of stroke. This is when a blood vessel breaks in the brain, a person loses control over one or both sides of their body. Typically, this can result in a lot of confusion, memory problems, hallucinations that can occur. So again, strokes certainly can result in behavior disorders in which you see these various symptoms of confusion and memory problems and hallucinations. Yet another form of biologically based disorder are the so-called dementias, of which there are a whole variety, different types of dementia. One is called senile psychosis, and I think that this was probably one of the first ones that was recognized in older versions of the DSM. Perhaps 100 years ago, it was referred to as hardening of the arteries. And what happens is, blood supply to the brain becomes choked off. And as a result of that, there are severe cognitive problems that occur in which intellect really disintegrates. And it is not uncommon to see individuals return, that is, lapse into a childlike state. Please don't confuse this with Alzheimer's disease. Though the symptoms appear to be the same, they have a very different etiology. That is the factors that produce it. So hardening of the arteries, this choking off of the blood supply to the brain, this is senile psychosis. This is a form of dementia, like Alzheimer's is a form of dementia as well. So Alzheimer's disease, certainly this is something that many in the World Health Organization refer to as the coming pandemic in the West. And that is because of the millions of cases, really, that are being diagnosed on a yearly basis. So what we've learned about Alzheimer's disease, certainly it's very, very severe disintegration in terms of thinking, reasoning, decision-making. Symptoms are very similar to that of senile psychosis, memory problems in terms of thinking and reasoning. What we also know is that there's degeneration that occurs in the hippocampus. And indeed, if you take a look at this cross-section here, this is an Alzheimer's brain, a hemisphere of an Alzheimer's brain. This is of a normal brain. And if you take a look at the language and memory areas, you can see this atrophy that occurs. And you can see the expansion of these sulci that occur in other parts of the brain, and also increase in terms of cell loss in the ventricular area of the brain. Compare this with what you see right here. One of the very interesting findings here has to do with the buildup of these what are called amyloid plaques and neurofibrillary tangles, and the production of this abnormal protein, which is called the tau protein. And these brown spots that you see here in the brain of an Alzheimer's individual, very characteristic of Alzheimer's disease, as well as what you see in terms of what are called neurofibrillary tangles that you see here and here. We don't know enough about this at this point in time in terms of the production of these abnormal proteins, but it's very likely that this plays a very important role in terms of the progression of this particular disorder. It's also associated with a reduction in the neurotransmitter acetylcholine in the hippocampus. Again, here's our hippocampal area that you see here, which is involved with memory. This is what it looks like in a Alzheimer's patient. This is in a normal patient. And it's also associated with a defect with some individuals in the 21st chromosome. So again, Alzheimer's disease, another one of these biologically based disorders. Very interesting movie and book that came out a few years ago that some of you might be familiar with. Lisa Genova wrote the book Still Alice, and it's about a young woman, a professor, who in her 30s begins to develop early onset Alzheimer's disease. And it's really her story. And if you're interested at all in understanding more about this, I would highly encourage you to read the book or to take a look at the movie by the same name, Still Alice. Julianne Moore won an Oscar for her performance in this, and it's really a great portrayal of what Alzheimer's disease actually looks like. Certainly, venereal disease can also produce behavior disorder. When germs that are associated with syphilis attack the brain, they can cause a paralysis, or what is often referred to as a general paresis. And you get cognitive deficits in advanced stages of this particular disorder, meaning changes in thinking, reasoning, and decision making. We also have certainly alcohol addiction disorder. And the more we learn about this, the more we're learning that early onset alcoholism does have a genetic basis. That if you have, if you're the son, for example, of an alcoholic father, then you have a fivefold in risk factor in terms of becoming alcoholic yourself. In alcoholism, there's a lot of denial and mood changes, aggressive behavior, deficits in terms of memory. Certainly in advanced stages of alcoholism, there's liver disease. In individuals that are chronic alcoholics, disorder that's called Korsakoff syndrome, you actually see brain changes. Here's some MRIs that you see here of a alcoholic individual and a normal individual, and this area that you see here in the corpus callosum and the ventricles is dramatically different than what you see here, again, in large ventricles in this Korsakoff's individual. So again, you're getting cell loss that's occurring. So genetic linkage, certainly this is something that is fairly well documented now. Drug addiction disorder, where we're taking a look at individuals that have become hooked on the classic, one of the classic drugs of abuse, like heroin, cocaine, for example. It's a brain disease. The brain has been hijacked. It's not a character defect. It's not a sign of mental weakness. There was a time when, for example, that whole strategy of just saying no was being promoted in order to treat addiction. Well, that was very naive because the brain essentially has changed, and it's not about mental weakness at all. It's really about these long-lasting kinds of changes that have been produced in the brain that produce this craving for this particular drug. Addictive substances generally increase dopamine activity in the synapses of a number of brain areas, and this is something that we've learned, and we're looking more and more at the very strong linkage between our biology and addiction, and a lot of it has to do with dopamine. So if you take a look at what is happening with cocaine addiction or methamphetamine addiction now, even with alcohol addiction, but with heroin addiction, you take a look at dopamine receptors in the brain, after a period of time, you get an increase in those dopamine receptors, but then they begin to decrease, and that is why an individual can no longer get the same degree of pleasure, that positive kind of hedonic state, unless they're administering more and more, self-administering more and more of that particular drug. But even then, what happens is the ability of these dopamine receptors to be produced diminishes. So if you take a look at a control individual and an addicted individual, you can see that in each one of these situations, and as the addiction progresses, the individual is less and less able to make these dopamine, to have these dopamine receptors available, and that indeed is a big factor in terms of understanding the nature of addiction to classic drugs of abuse. Manic depressive disorder, again, what we call bipolar disorder. you get this excitement and depression, and there increasingly we're finding these genetic links. Monozygotic twins share about a 50% concordance rate. Vincent van Gogh suffered from bipolar disorder, and this was his self-portrait, and this was completed shortly before he took his own life. Dizygotic twins, on the other hand, their concordance rate is only about 5 to 10%. If you take a look at brain changes, for example, in these individuals, this is the brain of an individual that's depressed, and you don't get anywhere near the amount of neural activation that you see in an individual that is not depressed. Schizophrenia, for sure. This is a very heavily researched area. Where you get this very severe personality disintegration. And one of the prominent theories in this area is something that's called the dopamine hypothesis of schizophrenia. And essentially what this is saying is that schizophrenia really is resulting from excessive activity at dopamine synapses, and this is occurring in the frontal part of the brain. So that is what is thought to be responsible in part for schizophrenia. There is also another hypothesis here that has to do with neurotransmitters, and that's the glutamate hypothesis. And what that is suggesting is that there's deficient activity that is occurring at glutamate receptors, which generally glutamate is an excitatory neurotransmitter within the brain. If you take a look at the frontal cortex of the brain, there's also some studies that implicate the frontal cortical area of the brain in schizophrenia. And certainly this genetic linkage that we know about, where, for example, in monozygotic twins, the concordance rate is about 48%. Whereas if we take a look at dizygotics, it's only about 17%. Again, that's very strong evidence that what we're looking at here is a genetic predisposition. It's certainly not accounting for all cases of schizophrenia. You know, there's certainly experiential and environmental components as well, but the more we learn about schizophrenia, the more we're learning that there is an important genetic component. The biology of schizophrenia, Fuller Torrey and Irving Gottesman have done really some spectacular research in this area, taking a look at the ventricles of twins that have schizophrenia, and those ventricles are larger than those of twins without schizophrenia. Again, you're getting a loss of brain tissue, and you're getting a fundamental altering of brain structure that's occurring. So if you take a look then, you know, here's our schizophrenic individual where you're getting this cell loss that's occurring in the ventricles, and also you're getting an atrophy of the sulci that you see here in comparison to that of the co-twin that is not schizophrenic. So again, this is you know, important research that's helping us to understand the biology of schizophrenia. This is a very interesting book that came out recently. It's called Hidden Valley Road: Inside the Mind of an American Family. And it's all about a family, a large family, in which 6 of the 12 children in this family were diagnosed with schizophrenia. And this was back in the 1950s. This is a book that just recently came out, and I've read parts of it. It's excellent, and it's a very interesting read because this was really some of the first indications that maybe what we're looking at is something that is heavily predisposed by genes. So I would encourage you to take a look at it. So it's really an very interesting read. Autism, certainly, this is a neurodevelopmental disorder. It's a lifelong condition of impaired social contact. You take a look at these individuals, they don't make eye contact, they don't make social contact with other individuals, they don't communicate very well at all, they have these repetitive speech patterns. They can't really initiate conversation at all and have sustained conversations. Their behaviors are very stereotyped. They have these repetitive kinds of movements that occur all the time. Typically, this is something that is noticed by parents before the age of 2. But in terms of understanding it, in terms of its underlying biology, we do have some information, but it's nothing that would allow us to say that this is a disorder that is completely due to biology. We can't make that determination yet. So there are brain abnormalities that do occur, but not consistently. 20% of autistic children have larger than normal heads and brains that are larger than 97% of most people. If you take a look at neurons in some brain regions, there's disruptions that occur in which there's abnormal connections. You take a look at the cerebellum, there's decreased number of neurons in the cerebellum. There's altered neuron structure in the cerebral cortex of the brain. There is a genetic predisposition, roughly 70% concordance rate, identical twins. That is when one member of an identical twin pair is diagnosed with autism. Chances are that 70% of the time the other one will be too. This is only a 10% concordance rate in the case of fraternal twins. So again, interesting information suggesting a genetic predisposition. What goes wrong in the brain of an autistic child? We're starting to get a handle on that. If you take a look, this is a normal brain, hemisphere of the brain that you see right here. Here's the ventricles, ventricle that you see right here. This is the brain of an autistic child. And what happens ordinarily is that these germinal cells, which originate here in the ventricular area, they migrate to the white matter and to the exterior of the cortex, the cerebral cortex. But in autism, you get abnormalities where in some cases they never reach the areas that they're supposed to go to. They never reach the cerebral cortex oftentimes. So in each layer then of the cerebral cortex, you have problems that are occurring in terms of these germinal cells that aren't dividing in the right way to how they eventually reach through the white matter and ultimately to the cerebral cortex. So again, that's some of the latest information in that area. So what we will begin to do in our next lecture is we're going to begin to look at therapies. So that will be our goal. Now that we know a little bit more about classification, know a little bit more about the DSM, then we're going to start taking a look at various therapies.